Hello friends, now we'll be discussing about spinal dysraphism. Before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. And the link for the notes is given in the description below. You can download it from there. So without further delay, let's get started. So spinal dysraphism. So dysraphism are the neural tube defects. So this neural tube forms from the neural placard at 21 days of gestation. So if these fail to form, there will be neural tube defects, that is spinal dysraphism. And folate supplementation before conception can help prevention of this issue, spinal dysraphism. And these condition is screened with ultrasound, amniotic fluid, increased alpha fetoprotein. Now the types of spinal dysraphism, that is spina bifida aperta, where we have open defect, and spina bifida occulta, where there is no open defect. So types of open defects are meningocele, meningomyelocele, myelocele, and syringomyelocele. Then spina bifida occulta, we have simple spina bifida occulta, spinal dermal sinus, lipomyelomeningocele, then diastematomylia, tethered spinal cord, and sometimes several types may coexist together. Now coming to one by one some of these, that is meningomyelocele, which is the most common spinal bifida aperta, most common type of spina bifida aperta. So here what happens is the protrusion of the varying amount of spinal neural tissue outside the spinal canal. So spinal cord is coming outside the spinal canal and causing issues. So there will be deficiency of skin, muscle and bony elements in the back. The neural placard will be open with exposed anywhere from thoracic to sacral level, and there would be neurological deficit, could be sensory, motor, even autonomic. And if it is at the thoracic level, there will be extensive defect. In case of sacral level, there will be only bladder involvement, and most cases are associated with hydrocephalus, and the chances increase in cases of thoracic defect and decrease in cases of sacral defect. And 90-95% are associated with chiari 2 malformation and other associated brain anomalies like corpus callosum anomaly, fused tectal plates, thalamic fusion. And now we see the management, that is the surgical closure of the meningomyelocele, and it is done within 24 to 48 hours to prevent infection, that is meningitis or ventriculitis. Before closure, we have to keep the baby in prone position, and moist sterile dressing is placed on the meningomyelocele. Prophylactic antibiotics is started, and in surgery we expose all the neural tissue. uh, all the exposed neural tissue has to be replaced and is considered viable unless proven otherwise. And the neural elements are carefully separated from the cutaneous elements to prevent dermoid, and dura is closed in a watertight fashion. Then we go for myofascial closure and skin closure. If it is small, we go for primary closure. If large, then we have to do skin grafting, and the treatment is combined with shunt placement and chiari decompression if needed. So this was all about treatment of meningomyelocele. Now myelocele, where there is arrested development of the spinal cord, most cases are stillborn, so there is increased mortality. Then syringomyelocele, where there is central canal of the spinal cord is dilated, so there is a syrinx in the between, and surrounding is the central spinal cord, which is dilated, and meninges are also outside. So there will be gross neurological deficit. In meningocele, there will be protrusion of dura and arachnoid matter, but the neural tissue remains within the spinal canal. So there is no neural element outside, no neurological deficit. So it's a simple repair, most commonly seen in the lumbar region. Now we have the spina bifida occulta, where we have simple spina bifida occulta, where there is no symptoms or deficit, Just the postural lumbar bone is defective. Dermal sinus, where we have a track from sinus to the subarachnoid space, and cutaneously there will be a dimple or pit, commonly in the lumbosacral region. Complication could be ascending infection and tethering of cord as the child grows, and it may be associated with intraspinal tumor, that is dermoid or lipoma. Treatment will be excision, track excision, and untethering of the cord. Now we see dystemmatomylia, that is spinal cord split into two hemichords by the bone or fibrous band that tethers the cord and prevents free movement or ascent of cord. It is associated with tuft of hairs and it needs a surgical repair. Then last one is the lipomeningomyelocele, where we have fatty tissue within the spinal canal associated with cord tethering, large dural defect, and neurological deficit. And there is increased incidence of post-op neurological deficit in surgery. And membrana renions, where the fibrous band connecting the skin to the spinal theca, causing cord tethering. So this was all about spinal dysraphism. Hope it has been understood and it will be nice for quick revision. Keep studying, keep growing. Please like, share, and subscribe. Never give up because great things take time. Thank you.